everyone. Still a few participants joining the list, so I think we will get started with our welcome and introductions. So yeah, this is another LiDCO clinical webinar to add to our series, which you can find on our YouTube channel. Feel free to subscribe there and get updates and notifications of any new material we post. Today's topic is around the subject of hemodynamic monitoring in risk surgery. And before I introduce today's speaker, just a few housekeeping points. So all attendees will remain on mute for the duration of the presentation. There is the chat function, which you can see as the little speech bubble on the right-hand side of your screen. The first message on there, as previously, is welcome, together with my email address if you prefer to send any questions or queries in directly to shane.dorish@lidco.com. Alternatively, you can post your questions in that chat function. You can send that directly to me as well, and we'll pose those to Frederic at the end of the session. Hopefully we'll have some time, maybe 15-20 minutes towards the end of the session, to pose lots of questions. The session will be recorded, and as I mentioned earlier, it will be posted on our YouTube channel. Now, speaker introduction. I'm very happy to have Dr. Frederic Michard join us again from Switzerland this evening. For those of you who missed our introductions last time, Frederic trained in intensive care medicine in Paris, then in critical care and anesthesia at the Mass General Hospital in Boston. About 4 years ago, he founded MiCo, Consulting.com, a Swiss consulting and research firm focusing on monitoring innovations. He's probably best known for his research work on pulse pressure variation and fluid responsiveness, with more than 9,000 citations on Google Scholar and more than 200,000 downloads from Biomed Central. He's given over 500 invited lectures on 5 continents on subjects ranging from heart-lung interactions, hemodynamic monitoring, fluid management, and then more recently, digital innovations, mobile monitoring, smartphone medical applications, wearable sensors, etc. Most recently, he led a large global survey on hemodynamic monitoring and management in COVID patients. Hopefully some of you have seen that. It was just published recently and soon to be available online. And with that, we seem to have reached a bit of a plateau on the participants. So good timing to hand over to Frederic, and you can get started.
Thank you very much, Shane. Hello, everyone. So before I start, I'd like to acknowledge again the fact that I'm today leading a consulting company based in Switzerland, and where we focus on digital innovations with medical applications. So I don't know if you're aware, but there are more than 300 million surgeries every year on the planet, non-ambulatory surgeries. And we know from recent publications that around 17% of these patients are going to develop at least one post-operative complication. So it's a large number of patients, over 50 million. We know as well from this paper published last year in the Lancet that around 4.2 million people die every year within 30 days of surgery, that it represents more death than those attributed to HIV, malaria, and tuberculosis combined. And this is actually today recognized as the third leading cause of death on the planet, death within 30 days of surgery. So what can we do to decrease the burden of post-operative complication? Clearly, first of all, we can implement the WHO surgical safety checklist. Surgeons can be less and less invasive. Anesthesiologists and intensivists can use protective mechanical ventilation. And we can optimize the hemodynamic status of our patients, and this is obviously what I'm going to focus on now. So by optimization, I mean individualization. And hemodynamic optimization would start by individualized fluid management. So what does it mean? It's actually pretty simple. We just need to be more rational when giving fluid. And we need to keep in mind this U-shaped relationship, which has been described years ago by Dr. Bellamy in this editorial. So U-shaped relationship between fluid load, the volume of fluid we give to our patients during the perioperative period on the x-axis, and the morbidity risk or the complication rate on the y-axis. So we need to keep in mind that if we don't give enough or if we give too much fluid, we will increase the likelihood to observe postoperative complications. So there is today clearly a consensus regarding the fact that giving too much fluid is a problem. There are still, in contrast, there are still clinicians who believe that fluid restriction may be the solution, particularly for GI surgery. So you may have seen this paper published a few years ago in the New England Journal of Medicine. It's a big international trial led by Paul Miles from Australia. And I think, honestly, when they designed this study, they saw as well that fluid restriction would probably be associated with a better outcome in patients undergoing major abdominal surgery. And so they were probably the first to be surprised by the results, because the only differences observed in this trial was actually a more acute kidney injury and more surgical site infection, SSI, in the restrictive group. So clearly, fluid restriction is not the solution even for GI surgeries. The solution is to individualize fluid therapy. Why? It's actually easy to understand. They are not two patients alike. You know that better than me. Patients may be different with regard to comorbidities. The clinical context, of course, is always different from one patient to the other. Some patients will receive bowel preparations, others will not. The preoperative hydration may be also very different from one patient to the other. Some anesthesiologists use pre-induction IV loading, others don't. And of course, intraoperative blood loss may be very different from one patient to the other. So for all these reasons, there's logically a large variability in the volume status of our surgical patients, explaining that some may benefit from liberal fluid administration, and others may actually benefit from fluid restriction. So the only way actually to ensure we always give the right amount of fluid at the right time is to individualize our fluid management. To acknowledge that one size cannot fit all, and then to tailor fluid administration to individual needs. And to do so, we need to assess fluid responsiveness. As a matter of fact, there are many randomized controlled trials published so far which have demonstrated some clinical benefits when individualizing fluid administration, when predicting fluid responsiveness in surgical patients. There are at least 50 randomized controlled trials showing benefits. So obviously, I'm not going to share with you all these studies. We have no time for that and would be probably boring. I just selected one. So I selected that study, first of all, because it was published in a top journal, the JAMA, a few years ago. Second, because it's the largest study published so far on this topic, on hemodynamic optimization during surgery. And third, because it's not a black or white study, as you will see in a minute. It's kind of gray, as often in medicine and real life. So when they designed the study, they were expecting a 20% decrease in postoperative morbidity, and so they calculated the sample size accordingly. And finally, they observed only a 16% decrease in postoperative morbidity, explaining that they did not reach statistical significance. You see the p-value was 0.07. So officially, it's a negative study. But then when they looked at the subgroup of patients in whom the protocol was followed, so not only the hemodynamic monitoring system was used, but the protocol in place was followed, then they were able actually to reach, or they observed, a significant decrease in postoperative morbidity. You see a 20% decrease, the one that was expected from the very beginning. And then it became significant with a p-value of 0.04. Also, when they looked at patients after excluding the first 10 patients per center, there is obviously a learning curve when you start using a new hemodynamic monitor with a new protocol. And so it made sense as well to look at this subgroup of patients. And in that case, you see that they were actually they observed a 41%, a dramatic decrease in post-operative morbidity that was obviously very significant from a statistical standpoint. Of course, it's very important to understand they were allowed to do this subgroup analysis because it was predefined. That's something they clearly acknowledged even before starting the study. Otherwise, it would not have been accepted in a paper like the JAMA. Even more interesting, this is a paper where they actually used the data from this JAMA paper, from this optimized trial, but using a different statistical approach. So instead of using the classical black and white approach you know very well, with the p-value below 0.05, it's positive, above 0.05, it's negative, they use what we call a Bayesian approach. And you probably see, like me, more and more actually clinical studies using the Bayesian approach. Why? Because it gives you a probability that something works. We know in real life it's never black or white, but there is a probability that something works a little bit or more, or actually a high probability. So that's the value of Bayesian approaches, which once again are used more and more in clinical studies. So when using a Bayesian statistical approach with the very same data from the optimized trial, the conclusion was that the probability that individualized fluid management, stroke volume optimization with fluid, decreased postoperative complication was somewhere between 96 and 99%. And so I think it's very, very interesting information. There are also meta-analyses showing the value of individualized fluid management. You know what are meta-analyses? We pool together all randomized controlled trials published on a topic. And so, for instance, in these recent meta-analyses published just a couple of years ago in the European Journal of Anesthesiology, the authors pooled 95 randomized controlled trials investigating the value or the impact of hemodynamic optimization during surgery. And what they observed when pooling the data from all studies published on the topic, so some showing a benefit and others failing to show any benefit. So when you pool all the data, at the end, actually, you can demonstrate a significant reduction in postoperative mortality, a significant reduction in postoperative cardiac arrhythmia, a significant reduction in pneumonia, in wound infection, in acute kidney injury, as well as in hospital length of stay. Finally, there are also before-after studies. So you know what they are. They are not very pure. They are not a reference, of course, from a research standpoint, but I think they are very important to ensure that what we demonstrate with randomized controlled trials actually works in real-life conditions. So this is probably the first before-after study done in the US and led by Maxime Canesson. Maxime is a French guy. When he moved to the US, he was obviously a believer in individualized fluid management, and he started to work at UCI, where actually they were not using these strategies. So they said, okay, let's try to do it and see what happens. So they compared the outcome of high-risk surgical patients before pre-implementation and after post-implementation, the use of stroke volume and stroke volume variation optimization protocol, very simple, based on fluid optimization. And you see what they observed, a significant decrease in hospital length of stay from 10 to 7 days that was associated and actually probably explained by a significant reduction in NESQIP complications. You see that the percentage of patients who developed at least one NESQIP complication dropped from 39% to 24%. These are two other before-after studies. These are actually pretty large before-after studies. The first one on the left was done in the UK. The second one on the right comes from Denmark. And they showed not only a reduction in postoperative morbidity, but actually a significant decrease in postoperative morbidity. And I think these are the only two studies which have been able so far to show a mortality reduction. So in summary, many randomized controlled trials, most, if not all, meta-analyses and before-after studies published so far reported some clinical benefits. And that's the reason why there are guidelines, recommendations published in many countries. In France, we have guidelines. In Spain, there are guidelines. In Brazil, in the UK, in China, and so on and so forth. Having said that, we also know from surveys, from audits, that the adoption of individualized fluid management, of hemodynamic optimization, is not that high. And one of the reasons, or one of the excuses often given by anesthesiologists, is that it's a money issue. I mean, hospitals don't have the equipment, don't have the funding to buy hemodynamic monitoring techniques. So if it's very important, of course, to acknowledge that hemodynamic monitoring have a cost, it's also important to realize that post-operative complications are very expensive. And so if we could decrease or prevent some post-operative complications, we could give our hospital the opportunity to save money. This is a summary of large studies with more than 1,000 patients, estimating the cost or the extra cost related to the development of post-operative complication. And you can see that when pulling all these studies together, the weighted average cost of post-operative complication is around $17,000. So complications are very expensive. And once again, if we could decrease only by 20%, 30%, 40%, maybe the proportion of patients who develop complications, we could also reduce hospital cost. So that's clearly something we have to take into account when you discuss with your financial department about the cost or the investment necessary for hemodynamic monitoring techniques. It's very important to realize that there are also potential savings on the other side. So to simplify the estimation of the return on investment, or to simplify the estimation of the possible investment hospital could make when buying hemodynamic equipment, I developed a very simple equation I call the Mercier equation. As you know, I'm French. And so the M stands for morbidity rate, the current morbidity rate for any surgical population you may have in mind. ER is the expected reduction in post-operative morbidity if you decide tomorrow to implement individualized fluid management for these patients. C is the average cost of complication for the specific patient population you may have in mind. And so I, the I from the Mercier equation, is actually the possible investment to improve quality of surgical care at no cost. So let me give you an example. It's easier to understand because that's an equation I used in a couple of studies. For example, that one I did with Sandy Fogel, who is a surgeon from the University of Virginia, and a few other people. That's something we published 5 years ago. And so Sandy had access to very interesting database in the US, which is a premier database where we have at the same time clinical and economic information, which is very often a challenge in Europe, I mean, to have these kind of databases. So we were able to look at a large population of patients, as you can see, over 200,000 patients from over 500 US hospitals. And all these patients had a major surgery. Of course, we focused on major surgeries because we know that's where individualized fluid management can make a difference. In this patient population, in this very large patient population, the average morbidity rate was 37%. So you see that once again, I mean, complications after a major surgery is clearly a big issue. The average extra cost related to or associated to the development of complication was around $12,000, so a bit less than the $17,000 I mentioned previously. And so if we use the expected reduction, the 16% reduction we observe in the optimized in the JAMA paper I showed you at the beginning of my presentation, we can estimate with the Mercier equation a possible investment around $700 per patient. In practice, you will probably pay around $200, maybe a bit more, to use hemodynamic monitoring, which means that if you effectively decrease post-operative morbidity by 16%, your hospital will actually save $500 per patient. So it's a way not only to improve outcome, but actually also to save money. And I showed you that we can predict with the Mercy equation savings around $500. As a matter of fact, this comes from a publication by SADIC in Perioperative Medicine. This is the economic evaluation of the JAMA paper I showed you at the beginning. These are real numbers. These are not projection as I did with the Mercy equation. These are real costs associated with the treatment of patients who did benefit from hemodynamic optimization and patients who did not. And you see that on the right-hand side, despite the fact that clinicians were using a hemodynamic monitoring system, it was actually associated with significant savings. So they not only improved outcome, they also saved money, or actually their hospital saved money. So that's, I think, very important to keep in mind. Having said that, clearly you understood the potential investment depends on the morbidity rate and the cost of complications. So if you have in mind very high-risk surgeries, the morbidity rate is usually high, and these patients develop sometimes major complications. And then clearly the return on investment is very often very positive. If now you plan to expand or to use hemodynamic optimization for medium risk procedures or in medium risk patients, and it's going to be a large volume of surgical procedure, you may as well acknowledge that maybe the morbidity rate will be lower, for example, only 15%. And of course, the average cost of complication may be lower as well, around 5,000, for example. And then the possible investments may be limited to $120. Then it's very important to be able to find hemodynamic monitoring solutions that will cost less than $120. And you know that there are actually some options now on the market to do so. The other reason for the poor adoption is the feeling that many anesthesiologists share with me, share with you, that it's complicated. There are so many studies published on the topic. They don't know exactly which tool they should use, which hemodynamic variables should be optimized, when and how. So I think we need to simplify the concept of hemodynamic optimization. And first of all, we need to clearly define who may benefit, who are the patients who may benefit the most. So I'm sure you are familiar with these kind of diagrams. There are many diagrams of that kind published. They plot the patient risk on the x-axis, the surgical risk on the y-axis, and they tell you when both the patient and the surgical risk is very high, of course, you need to use hemodynamic monitoring systems and optimize hemodynamic variables. In contrast, when there is no risk, you don't need these systems. But the limit, between low and high risk for the patient, for the surgery, is actually never really defined. So it's not really actionable. It's very useful to understand the concept, but not really useful at the bedside. So in practice, what can you do? You can do what many clinicians are doing. For comorbidities, they simply consider hemodynamic optimization for all patients who are ASA 3 and 4. And for the surgical risk, I mean, there are many criteria which have been used in publication. It's very often the duration of the surgery, the expected blood loss, the fact that patients are going to spend some time in the ICU after surgery. But I think one criteria is very easy to use is anytime you use an airline, anytime you decide your patient needs an airline, a radial catheter, it's because you are concerned by possible hemodynamic instability. And so I think it makes sense for all these patients in whom you use an airline to consider hemodynamic monitoring and hemodynamic optimization. Of course, if you like precision, you can precisely predict the risk of any individual patients. You know, there are surgical risk calculators available. That's an example of the NSQIP, the National Surgical Quality Improvement Program calculator, which is available from the American College of Surgery website. It has been validated using data from over 2 or 3 million patients in the US. And so if you give information about the procedure and about the patient, it will give you a precise prediction of serious complication, and any specific complication. And it will give you an estimation of the risk for your patient, but also it will give you an estimation of the average risk. And so clearly the risk for your patient is above average. I think it makes sense to optimize the surgical pathway, and of course it will include hemodynamic optimization, because we know it's a way to improve outcome and to minimize the likelihood of post-operative complications. So to summarize, the ABC of perioperative hemodynamic monitoring: A is to select patients who may benefit the most, and then B would be to choose and personalize hemodynamic targets. And that's also something we need to simplify and clarify. It has to be simple, otherwise it will not adapted. It will not be adopted, sorry. So for instance, you can use PPV, the pulse pressure variation, which is, you know, a quantification of the respiratory swings in pulse pressure induced by mechanical ventilation. We know it's a very accurate way to predict fluid responsiveness in mechanically ventilated patients, pending the tidal volume is at least 8 milliliters per kilogram, which is not always the case if you are using protective ventilation, protective mechanical ventilation. Having said that, it's not only a way to predict fluid responsiveness, it's a way to improve outcome. And this is a very first study where we investigated the potential value of PPV to guide fluid therapy and impact outcome. It was a pilot study we did in Brazil years ago. And when anesthesiologists were using PPV to guide fluid therapy, that's the intervention group in pink, and you see that they observed a significant decrease in postoperative complications that were associated with a significant decrease in the duration of mechanical ventilation, duration of ICU stay, and hospital stay. But that was a small and pilot study. We did with PPV. You can use SVV as well. SVV, if you have a cardiac output monitor that gives you stroke volume variation continuously, you know, the physiological meaning of PPV and SVV is more or less the same. And so in this meta-analysis we published a few years ago with Ian Benes, Maria Teresa Giglio, and Nicola Brienza, we pooled all clinical and outcome studies where anesthesiologists used either PPV or SVV to guide fluid management. And we looked at the impact on postoperative morbidity. And you see the odds ratio. On average, the odds ratio was 0.51, which means an average reduction of 49% in postoperative morbidity. So very easy to do, PPV or SVV, dramatic impact on postoperative outcome. But you probably know that there are some limitations, actually many limitations to the use of PPV and SVV. I already mentioned protective mechanical ventilation, but there are others, in particular increased abdominal pressure during laparoscopic surgery, for example. It's going to be very challenging to use or to interpret these values and these even changes in PPV and SVV. And so in this paper we published a few years ago with Denis Chemelin and Jean-Louis Teboul, we summarized all the limitations to the use of PPV and SVV by these mnemonic limits. So that's why more and more clinicians are focusing on stroke volume, because stroke volume is something you can easily monitor today with the Doppler or with pulse contour techniques. And you don't have all the limitations I mentioned for PPV and SVV. And the idea is to maintain the stroke volume close to the plateau of the Frank-Starling relationship. So to avoid to stay on the very steep portion of the Frank-Starling curve, to stay away from hypovolemia, but also to avoid fluid overload, which means that you will stop to give fluid as soon as you have reached the plateau of the Frank-Starling relationship. So it's a way to prevent both hypovolemia and fluid overload. So which tool should you use to monitor stroke volume? You can clearly use the Doppler. I mean, that's a technique which has been widely used, particularly in the UK, to describe this concept of individualized fluid management. And there are studies like that one. It's a randomized controlled trial. It's probably the most recent one, showing in 450 patients that when using the Doppler to monitor and optimize stroke volume, it was associated with a significant decrease, as you can see, in postoperative morbidity. Having said that, it's not always easy to use. Very often you need to reposition the probe. As you know, there are interferences with electrocautery, so it's operator dependent as well. And as a matter of fact, anesthesiologists clearly prefer pulse contour techniques and that was, I think, nicely illustrated by these two large studies. So USOS, over 46,000 patients from Europe, from 28 countries in Europe, and the recent RELIEF trial published in the New England Journal of Medicine, showing that when anesthesiologists were monitoring cardiac output, so they were not monitoring cardiac output very often, but when they were monitoring cardiac output, obviously most of the time they were using a pulse control technique. And honestly, I don't think it's because they are more accurate than other techniques. I think it's because they are really plug and play techniques and so very easy to use in the OR during surgery. By the way, I know some of you may have concern with these uncalibrated pulse control techniques used during surgery because they are not as accurate and precise as the SWAN or as echocardiography to measure cardiac output. Yes, clearly. But this is not what we expect. What we expect is to be able to track changes in stroke volume during a fluid challenge or when patients are bleeding. Anyway, to try to understand the impact of using these techniques in the OR, we did this other meta-analysis with Maria Teresa and Nicola Brienza. We published a few years ago in Anesthesiology, where we pooled all studies where anesthesiologists used uncalibrated pulse control techniques to measure hemodynamic variables and to guide fluid management, to individualize fluid management. And once again, we focused on the impact on post-operative morbidity, and you see the odds ratio was 0.46, which means an average reduction in 54%. So clearly, uncalibrated pulse control techniques are maybe not as accurate and precise than the Swan-Ganz catheter to measure cardiac output, but when they are used to guide fluid therapy by anesthesiologists, it has a significant impact on postoperative morbidity. We should not forget blood pressure. We speak so much about blood flow that sometimes some of us may forget that optimizing blood pressure is actually something important as well. And we can also individualize blood pressure management. That was proposed a few years ago by Emmanuel Futhier, a French international study published in the JAMA, where they measure the blood pressure the day before surgery and use the personal blood pressure as a target during surgery. So to be sure the blood pressure during surgery remain close to preoperative values, as you can imagine, they had very often to administer norepinephrine. But by doing so, they did report a very significant decrease in postoperative organ dysfunction. So I think there are two key messages from this study. The first one is that blood pressure does matter, because when you manipulate blood pressure, or if you have different strategies regarding blood pressure management, you have different results. And second, individualized blood pressure management is obviously better in terms of outcome, in terms of postoperative organ function, than classical management, where actually anesthesiologists were just reacting when the blood pressure was too low. So I just showed you a study showing that using the preoperative blood pressure value as a hemodynamic target during surgery is useful to improve outcome. Could we imagine to do the same with cardiac output? So could we as well individualize cardiac output management? To do so, we would need to know the baseline, the personal cardiac output of our patients before surgery. And there are not so many techniques enabling an easy and quick and cheap measurement of cardiac output during the preoperative visit. You could use echo, you could use Doppler, but it's time consuming and it's operator dependent. Maybe in the future, we'll be able to use some bioimpedance necklaces. But what we can use today are actually volume clamp methods that give us the opportunity to measure quickly and accurately blood pressure and cardiac output, non-invasively. So the question is, would using the preoperative cardiac output value as a hemodynamic target during surgery improve postoperative outcome as well? So we have one study to answer this question that was actually published just a few weeks ago in the British Journal of Anesthesia. It's a study from the group of Bernd Sogel from Germany. And so what they did is that they used this volume clamp technique before surgery to determine, to identify personal cardiac output values or individual cardiac output values for patients who had surgery and were monitored with an invasive pulse control technique during the procedure. And so they used the measurement of cardiac output done before surgery as a target during surgery. And the results are pretty promising. You see a significant decrease in a composite outcome variable, a composite of major postoperative complication and mortality. So a significant reduction when targeting individual personal cardiac output values during surgery. So this slide is actually a summary of the evolution of perioperative hemodynamic monitoring and management. At the very beginning, we were simply looking at CVP and maybe measuring cardiac output with a SWAT and just trying to normalize hemodynamic variables when they were outside normal ranges for the general population. And then it became, with Shoemaker, the concept of DO2 oxygen delivery optimization in very high-risk patients who had a Swan-Ganz catheter in place, and with studies showing outcome benefits. And then it has been fine-tuned with the individualized fluid management strategy, developed mainly in the UK at the beginning with Doppler system, and of course, more recently expanded with pulse contour techniques, which are, as I mentioned, extremely easy to use in the OR. And lately, we have this perioperative hemodynamic management 4.0 that could be the personalized approach where you individualize everything, fluid management, blood pressure management, and cardiac output management. So what would be the C of the ABC of perioperative hemodynamic monitoring? It could be simply maximizing time in target. Once you have identified the variables you want to optimize, it's very important. And once you have defined targets, which are very likely personalized target, right? You need to maximize the time in target. It makes sense to believe it's useful. And there is actually a very recent study, that one was published a few weeks ago as well by the team of Thomas Shiren, where they showed that the compliance to individualized fluid management protocols has a real impact on postoperative outcome. So in this outcome study, they used a very simple protocol based again on stroke volume variation or stroke volume optimization. And they defined compliance to the protocol by the quantification of the time spent in target. And they said when these variables are more than 85% of the time within target, it's a good compliance. If it's below 85%, it's not a good compliance. And when they compare the outcome of patient who is a good or a bad compliance to the protocol, and they observed a very significant difference. You see much less complications when there is a good compliance, when there is a lot of time spent within target. So we need to help clinicians follow protocols, and to do so, we can envision to use decision support systems, and in particular, visual decision support systems. Visual information is extremely useful. I think this slide speaks for itself, and you see the evolution of cockpits with multiple knobs and numbers to graphical display. So we have the same now on hemodynamic monitors. I mean, these are examples of tools available on the market. They were part of a publication with TJ Gann and Henry Kellett a few years ago in the British Journal of Anesthesia. And these are examples from the LiDCO monitor. So here you have the example of the protocol used at MD Anderson in the US. So of course you can upload your own protocol. And so the screen of your monitor is going to help you to follow step by step. I mean, the protocol you have decided to follow. The machine will never decide what you should do and which protocol you should use. It's just a tool designed to help you follow the protocol you have decided to follow. That's another screen. Let's say you do a fluid challenge, so it will automatically calculate the delta stroke volume. So you will know if your patient is on the steep portion of the Frank-Starling curve or the flat portion. Actually, it will even display the Frank-Starling relationship, so you will know exactly where the heart is operating. And this is another example of a target screen. So here it's a 2x2 matrix. So you have on the x-axis cardiac output, on the y-axis blood pressure, but it could be any variable you are interested in. And of course, if you define targets for blood pressure and for cardiac output, you will visualize the target zone in green and see if your patient is outside or within target. And it will, of course, help you to decide what should be done if you want to move back your patient within the target. And this is a recent study from Alexandre Justin from Belgium. where they showed that these visual tools, these visual decision support tools, are actually really useful to significantly improve protocol adherence in surgical patients. So in conclusion, I would say that in patients undergoing high-risk surgery, hemodynamic optimization is useful not only to decrease complications and length of stay, but also very often to decrease cost. A decrease in length of stay is something we need to keep in mind because it might be extremely useful these days with the surgical backlog related to the COVID-19 pandemic. So I think we need to try to optimize everything, any surgical pathway. We need to try to minimize hospital length of stay. And obviously, hemodynamic optimization is a key element of these enhanced recovery programs. To monitor blood flow, pulse contour methods are today the preferred choice of anesthetists. Do not forget blood pressure. I showed you many slides, many studies about blood flow, but we also know that blood pressure is a key determinant of organ perfusion. And if I had one advice to give you, if you want to implement more individualized blood pressure and cardiac output management, please keep it simple and use visual decision support tools. Otherwise, it's going to be challenging to get adoption in your department. With that, I thank you very much for your attention.
Merci, Frederic, indeed. Thank you very much for that great presentation, clear, coherent, and lots of great images and studies and data to boot. Just on the subject of studies, if there's any references within the presentation you might require, feel free to reach out to me at shane.dorish@lidco.com. I'm sure Frederic will be able to respond to an email if you send him one as well. But if you want to stick it in the chat, we can figure out, get those study references and get a response to you. We have a few questions that have come in. There's a couple just most recently, so let's try and get them in the order. I think this goes back to the beginning, near the beginning of the presentation, Frederic. Question on fluid restriction. So is there no real place for fluid restriction? Can't it be a solution for at least some patients in GI or neurosurgery?
So there are clearly patients like, as you said, a GI or neurosurgery is a very good example, where clearly you want probably to keep your patients more on the dry side than on the wet side. Having said that, there are clearly differences between patients. And I think I showed you a very important study, the study from Paul Miles, showing that fluid restriction is not the magic bullet. And so I think individualizing fluid management is important as well for clinical situations like thoracic surgery or neurosurgery, where clearly we are more concerned by the risk of fluid administration than by the risk of hypovolemia.
Okay, thank you. What are the limitations, or are there any limitations of using pulse pressure variation during laparoscopic procedures?
Yeah, so as I tried to explain, there are actually many situations where it's difficult to use PPV or SVV, and laparoscopic surgery is clearly one of them, because when you increase, because of the pneumoperitoneum you induce, you are going to significantly increase abdominal pressure that will be transmitted, at least in part, to the thoracic compartment. So you will also increase intrathoracic pressure or pleural pressure. By doing so, you will artificially increase PPV and SVV, independently of the volume status of your patient. So it becomes very difficult to interpret PPV and SVV values, and also changes in PPV and SVV during surgery, because they may simply be related to a change in intra-abdominal pressure. So for all these reasons, I think it's clearly a situation where we should measure stroke volume and optimize stroke volume and forget about PPV and SVV. And as we know, surgeons are using more and more laparoscopic strategies, and it's also a way to improve outcome to be less invasive during surgeries.
Okay, thank you. I think you touched on this subject in the presentation, so maybe do no harm to go over it again. What is more important in a hemodynamic monitoring technology for use in the OR? Accuracy of any parameter at a point in time, or trending accuracy?
I mean, as you understood, I mean, what we want to be able to do during surgery is to track changes in stroke volume and cardiac output induced by surgical bleeding or induced by fluid challenges. So it's obviously the ability to track changes in stroke volume and cardiac output we're interested in. And that's why we can accept to use these uncalibrated pulse control methods. Because we know, as I mentioned, they are not as accurate as an echocardiography, for example, to precisely measure cardiac output. So clearly, if you are in the ICU, you deal with a patient with septic shock. No, you deal with a patient with shock, and you don't know yet it's septic shock. You don't know yet your patient has a high cardiac output and low SVR, and so you need a precise measurement because the calculation of SVR is based on, of course, the cardiac output value. So you need, in that case, an accurate absolute cardiac output measurement. But in the OR, to guide fluid management, I think we can use uncalibrated pulse control methods, and we should use them because they are pretty easy to use.
Okay, thank you for that. Let's see, there seems to be a few questions around the recent information I think that you've just shared of the Soigel and Niklas 2020 paper. So let me try and group these together. So I think it's the practicalities of measuring cardiac output. Well, let's take the first one. So is the suggestion now that non-invasive preoperative measurements of cardiac output and stroke volume can be used to create intraoperative fluid targets?
You know, that's the idea developed by Bernd Sogel in this recent paper published in the British Journal of Anesthesia. It makes a lot of sense from a physiological standpoint. I think also for clinicians, very often we are a bit reluctant to use, I would say, arbitrary targets. We often question, you know, okay, I mean, studies have shown this and that, but is it really good for my patient? In contrast, I think many of us have absolutely no problem if the idea is just to ensure that a given patient we're going to target his personal values. If we know his normal blood pressure, his normal cardiac output, I think we'll have absolutely no difficulty to buy and accept this concept. So I believe a lot in the acceptation by the clinical community of this new concept. On the other hand, I showed you there is so far just one study showing that personalized cardiac output optimization is useful to improve outcome. And by the way, that study did not show it's better than a classical stroke volume optimization strategy. So I think we need more studies to clarify if it's really better than a classical stroke volume optimization study. But clearly the concept is extremely appealing.
Yeah, very encouraging. And I think within that, there was a couple of sort of practical questions you may be able to give your opinion on. So that, I guess it's around the whole preoperative assessment. There's a lot going on. Let's say, is there an ideal moment when that should be, when those hemodynamic parameters could be assessed? How close to surgery should it take place? Is it possible to get those baseline? I guess anxiety might play a part in some of the measurements, but do you think it's realistic?
So yeah, I think it's becoming realistic because we have tools enabling, of course, blood pressure, but also cardiac output measurements non-invasively and quickly on the wards the day before surgery. So to answer your question, clearly the temptation is to say, okay, let's do a quick check before anesthesia induction. But we all know, at least for blood pressure, and it's probably the same for cardiac output, that the measurements we are going to get are influenced by the stress, you know, right before surgery or the premedication given to the patient. And so usually for blood pressure, for instance, we don't pay too much attention if the blood pressure is too high because we say, okay, I mean, it's just the stress related to the fact the patient is going to have a surgery in a few minutes. So in these studies, the one from Futier, the one from Bernd Sogel, they clearly discuss the fact that it's probably the day before surgery or actually during the preoperative visit that could be organized, you know, days or even sometimes weeks before surgery that we should, of course, discuss with the patient, explain what means hemodynamic optimization, but also measure blood pressure. We always measure blood pressure, check the blood pressure. And if we have a volume clump technique, like the one you offer, we can easily at the same time actually measure cardiac output. So it could part of the information we collect during the preoperative visit, or if it doesn't, if it is not, sorry, if it was not done during the preoperative visit, that's something you could do the day before surgery on the wards, and then yes, it becomes possible. It becomes something, you know, that's something we could not imagine maybe 5-10 years ago, to measure cardiac output quickly the day before surgery. But today, clearly, if you have the device to do so, I mean, that's something easy to do.
Quickly and easily to allow that assessment. Yeah. Okay, let's go to this one. Again, another practical question, something similar, but again, this one's around patient selection. So how would you recommend, or what would you consider in the selection process for patients who may benefit from hemodynamic optimization?
So I try to be clear on that one as well. I said for comorbidities, you know, the ASA score is something you always calculate. So I think you should at least consider, if not use, at least consider hemodynamic optimization techniques for patients who are ASA 3 and 4. And regarding the surgical procedure, I think as well, I mean, anytime you use an A-line, why not connecting a pulse control algorithm to the blood pressure waveform you record anyway, and you display on your bedside monitor. So I think personally, I would have a surgery tomorrow with a continuous blood pressure monitoring with an A-line. I would probably kindly ask my anesthesiologist to look at my flow variables as well, because, you know, it's additional information you get without any additional invasiveness.
Great. Listen, I think we've come to the end of our questions. Most of the remaining questions have been dealt with during the presentation. As I mentioned, we're going to be posting this session on YouTube, so it'll be available for users to watch again at their convenience. All that remains for me is to thank you, Frederic, for your time this evening from Switzerland to present this great information. And we look forward, hopefully, to further webinars with you somewhere down the line. So thanks to everyone for your participation and engagement. And I think you'll join me in thanking Frederic once more for a great presentation.
Thank you very much, Shane. Thanks.
Thank you. Have a great evening. Take care. Bye-bye, everyone.